Hi, I'm Tom Burke, and welcome to Public Health on the Inside, your inside look into the world of public health. I'm the Associate Dean for Public Health Practice here at the Johns Hopkins Bloomberg School of Public Health, and through our series of podcasts, I would like to take you to the front lines of public health and introduce you to the world of public health practice. The world of public health practice is filled with opportunities and very difficult challenges, and that's what we'll explore on Public Health on the Inside. Today, I'm very pleased to introduce you to a friend and colleague in my own Department of Health Policy and Management, Dr. Thomas LaVeist. Thomas is the William C. and Nancy F. Richardson Professor in Health Policy and Director of the Hopkins Center for Health Disparities Solutions here at the Johns Hopkins Bloomberg School of Public Health. Thomas teaches courses in health policy and minority health, and I have to say, Thomas is a national resource on the issue of health disparities. So did you ever think about the secret to a long and healthy life? Now, some people say, well, the secret is have really healthy parents, but it's much more complex than that. And in the field of public health disparities, our guest, Dr. Thomas LaVeist, has looked into that very complex web of things that impact our health, from geography to race and ethnicity to social factors to behavioral factors. And he has worked through the science of that to help us as a nation better understand health disparities. Welcome, Thomas.
Well, thanks for having me. It's a pleasure to be here.
So, Thomas, health disparities, many students ask about it. It's one of our most popular areas now with new students coming into the field of public health, but it was not always that way.
Right.
Tell me a little bit about your work in the field, your background, and the evolution of the field of health disparities.
I discovered health disparities in a very interesting way. I was a student working on a PhD in political sociology many years ago, and as I was trying to understand something about quality of life of communities and how political power affected communities and the outcomes of the people that live there. And as I started to try to figure out how do I measure this, how do I express a good quality of life in the community, I kept coming up with these health measures or coming across measures of health. And the more I started learning about that, the more interested I became in statistics that I was finding that show that there were big differences in health outcomes across different racial and ethnic groups, gender groups, and socioeconomic status groups. And I became fascinated by that question. Why is it that your race, ethnicity, gender, socioeconomic status, geography, why do these factors play such a big role? Because like most people, I thought that health was really all about biology and genetics and access to health care.
Tell us a little bit about the scientific challenges.
Yeah, it's a big challenge scientifically, in large part because of the politics. It's impossible to totally separate the politics from science in the field of public health. And I actually am very sympathetic to the perspective that says we shouldn't be looking at the world through racial lenses. I'm very sympathetic to that perspective. The problem is that if we don't do that, how do we know if we have made progress in righting the wrongs and making changes to make the society more equitable across all groups? So I think we have to continue to do that. The big challenge has been getting access to data systems that collect the data in a way that's meaningful and useful. It wasn't until the late 1970s that we began to collect data by race and ethnicity for all groups. And I'm not sure that we still have it right. There certainly is a lot of variation within each of these groups that we missed the way we collect that data. But I think the science has definitely progressed, and we've certainly come a long way from my beginning in this area.
And some of that data actually paints a pretty difficult picture, though. For instance, I know looking at Baltimore, it's a city that has some very healthy neighborhoods and affluent communities, and also a city that has some almost developing world-like indicators of health. And you've worked with the city to try and raise awareness of this. Can you talk a little bit about that?
Yeah, we've done a number of things. The center that I direct, the Hopkins Center for Health Disparities Solutions, we have a number of projects that we do around the country, including some in Baltimore. We worked a lot with the community in the southwest part of the city that is a pretty interesting place. It's a racially integrated community, but it's a low-income community. So there you have black and white people living together in the same neighborhood, but they're living under very challenging social and economic conditions. And so we've gone in there and spent a lot of time collecting data on the community, working with that community to help them to develop community-based organization that is now doing public health practice work in that neighborhood. and to also understand something about the nature of disparities when people are living in the same geographic area with the same access to resources, or in this case, lack of access to resources, and whether or not the disparities that we see nationally exist in that environment. And one of the interesting findings from the research is that we don't find the disparities in neighborhoods like that to be similar to the disparities that we see nationally. In fact, we find that either there are no racial disparities, or when they are, they're a lot smaller than the gaps that we see nationally.
Thomas, you are also the director of our Center for Health Disparity Solutions. What kind of projects are you working on?
Well, we have several projects, a lot going on, but two that I think are particularly important and things that are coming up immediately. One is next year we'll be doing a conference called the International Conference on Health in the African Diaspora. And what we've done is we have identified scholars throughout the Western Hemisphere that are working on health in black populations throughout the hemisphere. Our plan is to bring them together for a conference, but not just a conference. The conference would ultimately lead to the creation of a network of people who could work together collaboratively to develop cross-national projects, to see what we can learn from each other and how we can help each other be more effective. Another project that we have is called the Culture Quality Collaborative, and this is a decidedly public health practice project where we've brought together hospitals from throughout several different states in the country to work on cultural competency in health care settings. Now, this is really, I think, important because cultural competency has pretty much been pretty soft in terms of how you measure it, how you identify if you are culturally competent, what does that even mean? And what we wanted to do is try to bring some rigor to this, some scientific rigor to this. So we developed first an assessment tool, a way for any healthcare organization to measure whether or not they are, in fact, culturally competent. Are they doing a good job of providing care to diverse patient populations? And we take these organizations through this assessment process, and then based on that assessment, we then create or try to innovate solutions to the problems that we identify. And we do evaluations to see if we can begin to create an evidence base on what can be done to help organizations to eliminate disparities in outcomes of patients that they're seeing.
That's great. Cultural competencies are so important in public health, too, with such diverse populations, and reaching out to them in times of disaster and in times of opportunities for prevention. So I think that work has far-reaching implications far beyond just the healthcare community, but for our field in general. So, Thomas, you mentioned politics.
Yeah.
And we know in public health, if you're going to make change, you have to roll up your sleeves and become involved in political issues, and you certainly are no stranger to that. You've worked with the Congress. How'd that go? And tell us how a scientist can be involved in the political arena while still being the scientist and not kind of crossing the lines of advocacy. It's a very difficult challenge these days, but you've succeeded in doing that.
Well, it's a constant work in progress, and working with Congress is a work in progress because it's an interesting,
Especially these days.
It's an interesting body, and it's constantly changing. And people in Congress are responding to different sets of interests. And what you have to do often is figure out what are the interests that this individual is responding to. And what I've tried to do in terms of working with political bodies like that is try to understand the perspective that they're coming from by understanding what set of interests is producing the outcomes or the perspectives that they're giving me, and then try to figure out how do I argue, in my case, devoting resources to addressing disparities, how do I make that argument fit within the political ideology of the individual that I'm talking to. So often we talk about health disparities as a social justice argument, and I think it is a social justice issue, of course, but I think it's more than a social justice issue. I think there's also an important utilitarian and economic argument that could be made, that there are economic implications for having people sicker than they should be.
In fact, that's one of your major contributions to the healthcare debate, was to bring the science on the economic burdens of health inequalities.
Right. We produced a report where we calculated the cost to the economy. What does it cost the U.S. economy to have a larger proportion of people that are sicker than they should be? What is the cost in terms of premature death, the cost in terms of overutilization of health services, what's the cost in terms of lost productivity to the economy? And to be able to put a dollar figure on that, help to create a set of arguments and hopefully persuade some people who wouldn't necessarily have sort of been brought to the table based on the social justice argument.
So, Thomas, I also know you as a friend and colleague. We've played a little bit of basketball together, and I know you as a creative guy, and you're always kind of looking for new ways to bring the public health science to not just the policymakers, but to the public through the web. And we've talked a little bit about one of your new ventures into the field of the movies. This is exciting. Tell me a little bit more about this.
I was having dinner with a friend who was in the music industry, and he said, I don't really understand what you do. What do you do? In other words, explain public health to me in 30 seconds.
Ooh, tough one.
I know, which is why you have a whole podcast.
That's
about it,
right.
And so the way I approached it was to try to talk about a book that I've been wanting to write, which is on health disparities, but not targeted to the academic or the policy audience, which is a little different than what I've done in the past, but targeted to the average man on the street, the general public. And as I explained this to him, his response was, well, you've got much more than a book here. He said, first of all, these people, the general public doesn't like to read. They want to watch movies. You ought to do a documentary. And first I thought he was crazy. What do I know about documentaries? And then just a series of unexplainable events happened, and I found myself in New York at a reception with Hopkins grads that are in the movie industry.
Amazing.
And they started asking me, what am I doing here? What are you into? And I told them what I was trying to do, and made these excellent connections with people who believe, as my friend did, that this should be a movie, not just a book. So I've learned much more about movie making than I ever thought I would. I'm not a filmmaker. I'm never going to call myself that because I have too much respect for what they do. But the idea is to do a documentary that would capture the interest of the general public and bring more awareness to this problem.
That would be great, because I think historically one of the things that we haven't been too good at in public health is really letting people know, the general public, about all the things we do.
Yeah.
So, Thomas, I want to kind of wrap up with a question for maybe prospective students or current students on your advice. Here you are taking one of the most difficult challenges we face, not just in this country, but internationally too, on health inequalities, and bringing the data to it, being creative, thinking of new ways to get the word out and the science out. What advice do you have for students who are interested in this field of health disparities and health inequalities?
When I began my career in public health, I didn't have the luxury of thinking about what to do. I sort of fell into it, and before I knew it, I was in a school of public health, and I was just trying to figure it out. And I've approached my career that way. And what I've learned is that whatever your talents are, whatever your interests are, there's a way for them to be used in a field like public health, because ultimately the health of the population is a manifestation of the health of the economic, social, political, cultural health of a people. And every aspect of society impacts health. So you can affect the health of populations through virtually everything, even the arts, music, science, movies. So what I would say is think about what your skill set is and how you can bring that skill set to bear in addressing the problems that this society faces. And I think for me, the problem that I'd like to see us affect, and we could certainly use more help with more people working on this problem, is why is it that some people live sicker and die younger than others?
Thomas, thank you so much for the work you do and for being here today. And it's terrific to have you here on Public Health on the Inside. And thank you all for joining us. I'll see you again soon.